We learned yesterday that our speaker, Dr. Dorie Smith, has been exposed to COVID. And so she isn't able to come here to be on site with us. However, she's happy to give us the presentation on Zoom, which we'll be watching on the big screen here at Las Campanas. Dr. Smith is a speech language pathologist, clinical singing voice specialist who earned her doctorate in vocal performance and second master's degree in speech, language, and hearing sciences from the University of Arizona. She currently serves as an assistant clinical professor in the Department of Speech, Language, and Hearing Sciences at the University of Arizona. And she practices at the UA Speech, Language, and Hearing Clinic and Banner University Medical Center. Prior to entering the field of speech language pathology, Dr. Smith served on the music faculty at Fort Lewis College in Durango, Colorado. On the stage, she has performed across the US with companies such as Opera Maine, Mass Opera, and Arizona Opera. She has also performed in Milan, Italy. Dr. Smith, we are happy to have you with us today as speech and swallowing are major concerns for people with Parkinson's. So I will turn it over to you.
Thank you so much, Charlene. And also thank you, John and Cindy and Evelyn, for all of your organizational expertise and for all of you to be here. I wish I could be with you in person, but I would be happy to visit at another time and to be an ongoing resource for you all if there's any way that I can serve you or direct you in search of care or answer any questions at all. So thank you again for having me. This is quite a pleasure. So I'm going to share my screen at this time. I have a PowerPoint that you can use for visual reference. Also, I'm a firm believer that things should be, excuse me, I just want to make sure I'm sharing this properly. Things should be interactive and fun. So I'm going to put you all to work a little bit too. I'm just getting my PowerPoint up here. We'll be ready to go. Please feel free to interrupt me at any time if you have questions. We'll also save time at the end. But I am here for you. So even if we deviate from what I have planned, that is okay. I'm here to meet your needs. All right, here comes my PowerPoint. Can we see that okay, Cindy?
Yes, that's fine. Thank you.
Perfect. My pleasure. So as Charlene mentioned, I'll be talking about voice swallowing and communication therapy for individuals with Parkinson's disease. I work with a wide variety of individuals with Parkinson's disease at both of my clinics. And I am just delighted to speak on these very, very important issues and hopefully to provide some additional information to reinforce all of the knowledge that you've already accumulated and put into practice and talk about some future directions, things that are applicable to you right now that you could even start doing at home if you're not already. All right, just a little bit about what a speech language pathologist does. You heard a little bit about my background, so I won't reiterate that again, but the master's degree is considered the terminal degree for a speech language pathologist. We're certified by the American Speech Language and Hearing Association, or ASHA. We undergo a national examination. We do a year-long clinical fellowship to make sure that our clinical skills are up to snuff and that we continue to improve our knowledge in order to best serve the public, right? So that's something that's so important to us, is that we're meeting the needs of our patients. And we know that these are ongoing and developing needs. So we do our best to keep very current with research and other trends so that we can make sure that you're getting the best, because you deserve that. We're also licensed by the state. If you're ever in search of a speech language pathologist, if it's in the Tucson or greater Arizona area, I'm happy to help you. I'll give you a handful of names of people who specialize in different areas. You could also, if you're interested in LSVT, you can also go to lsvt.org if you're looking for that particular program and to search for a practitioner. So the role of the SLP is the evaluation and treatment of communication disorders. We want to make sure that people are able to participate fully in all of the activities that they want to do. And this involves making sure that we're getting a baseline, that we're facilitating improvement and promoting positive change in the direction that is most meaningful to our clients, and also making sure that we're maintaining that progress. And especially with neurodegenerative disease like Parkinson's, we want to make sure that we keep and maintain function and promote the best quality of life possible, as I know that is a shared goal for all of us. So we treat speech, voice, and cognition and language. And we also participate in the evaluation and treatment of swallowing disorders, along with some other medical professionals. I often refer to the World Health Organization's International Classification of Functioning, Disability, and Health, because they specifically call on SLPs to provide care that impacts all aspects of an individual's experience with communication, with a communication disorder. So that includes their participation in valued life situations. And there are so many. So we endeavor to provide really person-centered care that takes into consideration all of the dimensions of a person's life, embodying respect for client autonomy and choice, and valuing the individual needs of that person. So this is a therapeutic alliance with a focus on the patient, on the person, and as part of a larger team as well. So I've listed a bunch of different professionals who participate in this multidisciplinary collaborative care. It's good to have a team. It's like you're a rock star and this is your support team. I mean, if you still want to add an entourage to that, I am all for it. You go for it. But for individuals with Parkinson's, it kind of takes a village. And I didn't put the two main people on the team here, which are the patient, the individual, and their caregivers, their family, their loved ones, the people that they talk with, who know them well and can also very fully participate in this process. So that team may include a primary care physician. It's so important to find someone good who can help coordinate care. The medical system, I wish, were more accessible and more transparent and easy to get information and make appointments and facilitate referrals. But unfortunately, as many of you probably understand and discuss within your group, we have issues with access in our country. And it can be very difficult or seem like a part-time or full-time job just to coordinate and manage all of these different appointments and to know who to see. So I'm so glad that organizations such as yours exist because they're necessary, thinking about all of the functional, emotional, financial, medical aspects that involve Parkinson's. A neurologist, a movement specialist, a neurosurgeon, if you have a deep brain stimulator and need that programmed or inserted, a laryngologist. This is an ear, nose, and throat physician who has an additional fellowship on top of a residency to specialize in the larynx. And I work very closely with a laryngologist. There are 3 of them in Tucson at Banner UMC. And we do a lot of collaborative care for Parkinson's patients. A speech language pathologist. Ta-da! A physical therapist, and sometimes a neuropsychologist or psychiatrist. All right. So these are probably pretty familiar terms. If they're not, tremor can involve the chin or tongue. It's roughly found in about 55% of patients with Parkinson's. There was a study by Perez and colleagues that found this. There can be rigidity, so increased muscle tone that can change posture and neck alignment. There can also be bradykinesia, that slowed movement and that decreased range of motion. And those have kind of cascading effects in the sense that this slowed movement, decreased range of motion can affect voice. It can affect speech. It can affect your swallowing muscles. It can also mean that you have difficulty initiating, starting movements and meeting the targets. And changes to facial expression can also be involved. And that ability to rapidly respond, for example, jumping into conversation. So we can think of all the functional ways that that may negatively or deleteriously impact someone's ability to compete in a conversation with others or against background noise in a loud environment. So those are some things that we try to control for and troubleshoot to make sure that regardless of where you are and who you're talking to, that you can express yourself. All right, I did want to mention some numbers. Here are some numbers for thought. Disorders of voice and speech in persons with Parkinson's is estimated to be 75 to 85%. So that's a lot. Now, keep in mind that the severity is typically is often directly related to the other physical symptoms that are seen. It's really across a spectrum. And despite that high incidence of speech and voice problems, only about 3 to 4% of people with Parkinson's disease receive treatment for speech and voice problems. Now, to me, that says, well, we've got some work to do. To me, that says I've got a mission, because if you need me, I'm here. It's really important that this can be assessed, this can be monitored, and that we can work together as a team to try to improve quality of life. So about 30% of the patients who have speech, language, and voice problems, about 30% of those people find that to be the most disabling part of the disorder. I am certainly biased, but I can tell you that speech and voice is important. Communication is important. It also, and I'm sure we've all felt this in one way or another, also closely aligns with identity, expression of self, our personality. And that's an essential element that we don't want to lose. We don't want to lose sharing that with other people. I'm sure the people around you don't want that to deteriorate in you either. So just putting that out there. The timeliness of intervention is something to consider. Voice therapy is of great benefit to persons with Parkinson's in the early to mid stages of speech and voice difficulty. So I've defined some of these right here. So early to mid stages, we do some rehabilitative voice therapy. What's nice is we can introduce the topics and the concepts early on so that you get a feel for them. They become more second nature. You know what to do. You can use an amplifier if you need it, if you have difficulty being heard in your various environments. Also, I have to say, the patients with Parkinson's that I work with tend to be some of the most active people on my caseload. And I see people across the lifespan. You all do so much for your community, for your friends, for yourselves, for your employers. It's absolutely remarkable. So we want to make sure that we make adaptations and adjustments to make sure that you're able to do all the things that you want to do. In the later stages, behavioral and or environmental techniques. In a small portion of Parkinson's patients, all speech may be lost. And in that time, alphabet supplementation using visual support such as letter boards to give the listener visual cues and to help control the rate of speech helps. Also an augmentative and alternative communication device, like using technology like an iPad to supplement, may be necessary. Again, this is a very small portion of the population. And that's really because of decline in overall motor control and cognitive impairment. And those AAC devices can be difficult to teach and use. So letter by letter typing with speech print output is basically what they do. So voice therapy becomes less effective as we go on, just because there are neurocognitive changes that decline. So it's even most severe patients with Parkinson's can still communicate with cues to speak loudly. So that cueing in the work that we do together becomes really helpful to not only listen to yourself and to your own body, but also to get some external feedback, right? Whether that's from a decibel reader on your smartphone, or whether that's getting feedback from your loved ones, or they can encourage you to use your cues of speak with intent or speak loud or use crisp, clear consonants. And those are things that we will also play with towards the end of this presentation as well. Boy, is there a lot going on. Don't be intimidated by all of these many names. I meant to show this to you because the voice and speech and swallowing mechanisms, they're really right next to each other. This is dense real estate that involves complex coordination. I think that it is pretty marvelous. It's a marvel of nature and science. And there's so much that we can do to facilitate change without any kind of surgery or larger intervention. So I firmly believe in our abilities to optimize our voices here. So fluorographic studies have demonstrated the most common projection of progression of vocal tract symptoms. Now, your vocal tract is basically everything that is above your vocal folds all the way to your mouth. You can think of this kind of like a tube that we can shape and press and mold into a different voice or different shades of the same voice. So, all those comics you see on Netflix specials or, your favorite Kermit the Frog cartoons, they're shaping their vocal tracts. There's a lot of things we can do to change our voices. But what typically happens is it begins with laryngeal dysfunction, which is one of the reasons that we recommend seeing an SLP laryngologist team to look at the vocal folds themselves. This then is followed by alterations in lingual, so that's your tongue, and labial functions, that's your lips. So changes in that musculature and the rate and the timing and kind of the responsiveness as it coordinates with other parts of your body can change as well. So here's what we often hear. The voice is too quiet, it's fading, it's soft, it's hoarse. It's kind of a catch-all, right? It could be pretty rough, it could be quiet, it could be strained. Hard to say. It could be also monotone. You may notice that your voice may not be quite as musical with all of those ups and downs and contours as it previously was. You may also notice some speech imprecision, that it's not quite as clear or as crisp as it used to be. It may sound kind of blurred. This is also referred to as dysarthria. The rate additionally can be too fast. It could be slightly irregular, or it could kind of feel like a runaway train. We call those rushes of speech. And we also, to note, posture interferes with communication too. So all of those body symptoms, whole system, whole person changes can also impact voice and speech, because posture interferes with breath support. It interferes with volume in a sense, right? Because our breath, our air powers our voices. And if our power source can't adequately expand, let all of that air in, it's going to be a little bit problematic for that support of our voices. Volume, poor eye contact as well, if there's postural changes. And it's worth noting that, speaking about the voice in particular and your vocal folds, vocal folds create sound by vibrating against one another very quickly in cycles per second. For example, my vocal folds as I'm speaking are probably vibrating about 208 times per second, which sounds very impressive. Thank you. But for women, it tends to be like right around like 190 to about 220 hertz. Men are below that, from about 76 to 150 or so. And then there's kind of a neutral range in between too. It's worth noting that also men's voices go higher as we age, and women's voices get lower as we age. So that's kind of the natural process for all human beings, regardless of any kind of other diagnosis. So vocal fold vibration requires that exhaled air pressure. We need to transfer that energy and send it out to get strong voice. And about 40 to 60% of a big breath provides just the right amount of pressure to make the vocal folds vibrate without you having to think about it or work for it, without you exerting extra pressure from the level of your throat. We probably all felt that as we, yelled at a ball game or to a friend across a crowded restaurant. We can feel a little bit of that strain. That's our body telling us, find another way or back off a bit. Let's find another way. It's also worth noting that perception of patients with Parkinson's may not align with perception of care partners and friends. Part of this is because with Parkinson's, that feedback loop, that auditory feedback loop is interrupted in the sense that grand movements, grand gesture, loud sounds are not registering as loud. So the person with Parkinson's may be speaking in a very, very quiet voice and think that it's a very, very loud sound. It's because that feedback loop is interrupted. Same thing with gestures. There can be somewhat of a physical retreat versus large gestures and occupying more space. So there's a little bit of a disconnect that involves some conversation and some compensation and supporting each other to provide cues to help get that voice loud and out there. There are also age-related changes that affect us all. In fact, the aging process for voice starts in the late 30s. So your vocal folds change too as you age because the vocal folds are muscles, just like any other muscles in your body. So the mass changes and the stiffness changes. So the mass decreases because you lose a little bit of muscle bulk in your vocal folds. And the stiffness increases as well. As we age, our elastin, a protein that is throughout the body and in our skin, etc., gets replaced with collagen, which is more structural and not nearly as flexible. I'm sure you've seen skincare products advertised that say collagen, collagen, collagen. Well, yeah, we need structure and we need springiness. So what that can add up to is that they don't move the same way. Because if you think of something that's nice and squishy and pliable that vibrates really, really well, if suddenly it's lost a little bit of bulk and it's stiffer, requires more energy to move it, that's going to equal more work. Additionally, in our respiratory system, pliability and capacity changes in our lungs. And that's our power source for our voices. Other people matter too. You want to think about who your interlocutors, who the people are who you talk to a lot. Do they have any kind of hearing impairment? I see a lot of patients for whom they and their partners have the perfect storm, the perfect combination of a voice disorder and a hearing impairment, or sometimes it even exists within the same person. That can make it even harder to hear yourself and adequately assess or accurately assess. Also, situations and environments can really impact this. If you consider, I don't know how many people are eating out at restaurants right now, but there's been a trend over the past 10 years with this new industrial chic style where restaurants are incredibly loud and boomy. There's nothing to dampen the sound. The sound just bounces off all of the metal ductwork. And that creates problems communicating. Right? You want to go out for happy hour and see your friends and catch up, but you may find that afterwards you feel considerably fatigued. So you may not have seen these before, maybe you have. These are vocal folds. So this is a large part of what I do, and I think they are absolutely beautiful. So your vocal folds are about the size of a walnut. They go this way in your throat from front to back in the larynx. And they're the entrance to your airway. If you look at the first picture here, you can actually see through this gap right here, that's staring down into your trachea. That's why it's dark. On the far right, you see young vocal folds with no disorder. You can see that they're making a nice tight seal against one another. So when they're vibrating, whoops, I got excited and I switched the slide, vocal folds. So you can see they're making a nice tight seal, so no air is escaping. Then on the far left, the vocal folds that have the gap, you'll see that this person has lost a little bit of muscular bulk. So the vocal folds are somewhat bowed in appearance. You can see they've got a slightly spindle-shaped gap there. So that's kind of equivalent to having a leaky valve. So you go to make sound and it comes out a little breathier because they're not closing entirely. You're losing energy as they vibrate to make sound. So what happens sometimes is supraglottic constriction, where you can say squeeze. So that's a sign of effort, because what our body naturally does when there's a leak, it plugs it. You compensate. Your body picks up and tries to do whatever it can to replicate the same sound with the anatomy it's got. So a lot of that squeeze can take place. So this is why it's very helpful to do a full voice evaluation, because it's not just enough to say to someone, get louder, because we don't get loud the same way. I can make a big, boomy, supported voice, or I can yell, right? So the second part, and I hope I wasn't screaming too loud for your area. The second part was me squeezing. Hey, really straining. You might have even been able to see some of these muscles in my throat starting to bulge as I put forth that effort to talk. So what we like to do is try to avoid straining, but try to get the most efficient voice we can, sending lots of energy into the system without increasing resistance to the energy, without that squeeze in the throat. All right, so prior to beginning therapy, a comprehensive voice evaluation is recommended, including visualizing the vocal folds, because that's the best way of knowing what your needs are. What's going on down there? What are their specific needs? With that knowledge of anatomy and how your vocal folds are vibrating, we can do more tailored treatment. So traditional approaches for therapy for individuals with Parkinson's include changing the loudness, the rate of speaking to try to improve clarity, articulation, trying to have clear, crisp consonants, a nice clear speech, promoting the use of at-home exercises to keep reinforcing the principles. Some of the best known and best research techniques include the Lee Silverman voice treatment, or LSVT. There is also a physical component program, which is LSVT Big, which does movements. Similar to the Power Gym, which many of you attend, which has a just wonderful programming and is, run and founded by one of our very distinguished alumna. There's also Speak Out, and this was founded by Professor Emeritus Daniel Boone, who sadly passed away within the last couple of years, and the Loud Crowd, which is group therapy. And Speak Out uses intent. So Professor Boone found out that by trying to give patients cues about intention to communicate, making the voice exciting, putting thought and feeling behind your utterances, it can really improve voice across many different categories. We also provide compensatory strategies and amplification. Whatever your life is, whatever your needs are, we're going to try to find solutions. And that's why it's pretty personalized, as well it should be. So I'm going to mention a couple of practical things. In discussing this, here are some suggestions for now for home. So keep talking. It's kind of a use it or lose it situation, in the sense that these are muscles. We want to keep them healthy and working. We also want to improve coordination. We want your breathing, your vocal fold vibration, and your resonance, kind of your natural amplifiers, to be working in sync, to be collaborating and coordinating. Learn to notice when others cannot hear you. And you can even speak with the people around you to say, please let me know if you can't hear me. I'm working on my loudness, or I'm working on keeping my speech clear. If sharing some of your goals is helpful, do it. That's a nice way to bring others into the fold and as part of your team. Try to speak louder. It can be helpful to read out loud. That's a nice application of some of these principles, whether it's, reading some of the morning newspaper to your spouse, or a piece of poetry that maybe you haven't picked up since your college days, or reciting the song lyrics to your favorite song. Speaking of, sing. That's wonderful for your whole body. Truly, that is putting that coordination to the test. And it's doing something that's hopefully really enjoyable to you and to others. But I'll tell you right now, a lot of people say that they can't sing. I firmly believe that most people can sing. And even if you're one of those who says, nope, really can't, I lip sync. Find a place where you can let it out because it's good for you. You don't even have to share it. It's good to have a visual reference and a little bit of additional information. So looking at the person you're talking to helps a lot, especially considering that there may be hearing loss at play as well. Turning down the background noise, trying to achieve like a better acoustic environment is great. Even if you're at in a loud space, even just telling someone or gesturing to them to try to pull them into a space that's quieter so you can be heard and understood is a good solution. And also consider using an EMST 150 device after consulting with your doctor or therapist. So I'm going to talk a little bit about that because this isn't necessarily something that you need to see a speech therapist for. It's something you could self-start at home, but I would recommend talking to a professional about it because there are a couple of contraindications that usually relate to stroke or pulmonary or cardiac disorders. So we want to make sure we go about it safely, but EMSTs are pretty safe for everybody. So the EMST, and I'm not affiliated with this company whatsoever, besides that the evidence supports their products, is an expiratory muscle strength training device. So the expiratory muscles are the ones that we use to get the sound out when we speak and when we blow air out, right? So we also, when we cough. So I'm going to talk a little bit about that because I want to, again, give you something functional that you can do even without me. Just talk to your doctor. So an expiratory muscle strength trainer improves cough and swallow function in patients for risk for aspiration. So we know that ultimately aspiration can lead to pneumonia. And unfortunately, pneumonia is the #1 cause of death for individuals with Parkinson's disease. So coughing is both the voluntary and involuntary. Sometimes we do it intentionally, sometimes we do it involuntarily. It's the primary method of clearing our airway of any particles that may have made it to our lungs. And there are 3 important components to coughing: the inhale, that closure of our vocal folds to protect our airway, and a strong exhale. So EMST has been found to improve cough and swallow function, and it's a great treatment modality focusing on that airway protection while also increasing cough effectiveness. And it uses, you can probably see it down here. If it were in person, I would show you one and pass it around. I'm happy to come back. It uses this calibrated one-way spring-loaded valve to basically overload those expiratory muscles mechanically, so it can strengthen them. The good news is that it's suitable for almost anyone. It's non-medicinal and shouldn't have any side effects. But again, I would speak with your doctor, your physical therapist, or your speech language pathologist to see whether it's appropriate for you. Now, I will, let's make sure that this comes up. It does. Can you see my screen still? Mm-hmm. Perfect. So I would be happy to send this to you if this is of interest. I have basic quick start instructions for how to use an EMST, and it is quick and easy. If any of you would be interested in this, I would be happy to share it. That way, if this is something you're interested in, you could get started after talking to your doctor. It can be bought online, and Medicare even reimburses you for it. Thank goodness. That happened over the past year, and that's the result of people like me telling our national organizations to advocate for it, saying, no, this should be covered. The evidence says it's good for people. So happy to send that your way or even answer questions for you if you have any. All right, there are unfortunately some changes also to cognition and language with Parkinson's. Attention is to what we see and hear and to the task. Being focused versus distracted by extraneous information, switching attention, maintaining attention, and splitting attention, which is when we try to multitask. However, I will say right now, many studies, the overwhelming majority of studies have shown that as humans, with or without any kind of disorder, we are not good multitaskers. And our world seems to demand more and more that we multitask. So part of that is cultural and how we're wired. But it is important to be gentle with oneself, to be patient as caregivers and family loved ones with patients with Parkinson's if they have any of these symptoms, any difficulty with these things. Memory, it tends to be short-term memory. Executive function involves problem solving, planning, executing, and repairing. Changes to personality could mean some anxiety and being rigidly set to a routine or some lack of flexibility. To be fair, we experience more concrete thinking and lack of flexibility as we grow older anyway. There can be changes directly to the brain. I've put some of these here. These are always things that I check in with my patients about because quality of life is everything. And if there's anything that myself that I could do or any of the other care providers could do to help with these, it's important that they be addressed. And even though these aren't fun to talk about or look at or hear about, it's important that we know that this is a possibility so that we can continue to check in with ourselves and others can check in with us. Because again, it's about quality of life, keeping you doing all of the marvelous things that you do at whatever level you want to do them. Sometimes there is more occurrence of moments of anomia or trouble finding the right words. It may feel like it's right on the tip of your tongue. And maybe there may be some reduced verbal fluency. There might be some pausing or some hesitation. There also could be difficulty with attention, memory, and problem solving. Let's skip right to the fun part of suggestions for home. So, compensatory strategies can really help. The gift of time with people, right? Time for yourself, time with your loved ones, support. Routines, schedules, setting expectations can be really helpful as well. It's also great to stay mentally active, read newspapers, read novels, read graphic novels, anything that makes you happy and engages your brain. All of them do. Reading is miraculous. Do crossword puzzles, Sudoku, word games, memory games, something that gets you intellectually involved, or that maybe some board games or cards where you're actively engaging in problem solving. Also, you're interacting with other people, and that is the absolute best. Socializing. There's no replacement for it. And I know that it's increasingly more difficult during a global pandemic. But I think we've all realized in our own way how essential it is to maintain contact with people and how it's hard to be alone. So go to some of these support group events. It sounds like you have so much going on, and I think it's wonderful. You know, have a Zoom meeting with friends or neighbors across the country that you miss. Try to socialize and stay engaged, even when it's so tempting sometimes because of your other symptoms or your speech and language symptoms or voice for you to feel like you want to retreat or that it takes too much energy or effort. Be gentle on yourself, pace yourself, but push yourself too. All right, I'm going to talk a little bit about swallowing now. So eating and swallowing are remarkably complex behaviors. They involve volitional and reflexive activities of more than 30 nerves and muscles. That's a lot. That is a lot. And it's not really something we learn how to do. We just kind of do it when we're younger. They have two crucial biological features. So there's food passage from the oral cavity to the stomach for airway protection. Okay, I would say actually that airway protection might be number one. So the swallowing process is commonly divided into oral, pharyngeal as the back of the throat, and the esophageal stages according to the location of the food or liquid. So that movement of the food in the oral cavity and the oral pharynx as it gets to the back of your throat differs between eating solid food and drinking liquid. And dysphagia or difficulty swallowing can result from a wide variety of functional or anatomical, more structural deficits of the oral cavity, the back of the throat, the pharynx, the larynx, the voice box, or the esophagus. So it's kind of this complex choreographed dance that all the partners need to be working in tandem well. And unfortunately, dysfunction happens with Parkinson's. So we want to make sure that we're doing whatever we can to problem solve. So these are some of the changes related to swallowing with Parkinson's disease. Dysphagia is a very frequent and highly relevant symptom for quality of life, for morbidity and remaining timeline. And unfortunately, it is very underestimated and widely undiagnosed regarding patient-centered care. So especially in the early stages of having difficulty swallowing, that causal association between disease and swallowing difficulties remains unnoticed. So that may be accounted for because it's difficult for caregivers and even for physicians to detect subtle swallowing problems. And it's also worth noting that it can be difficult for the person with Parkinson's to identify problems because there are changes in sensation in the swallowing process. So they may have trouble swallowing and not know it. So in order to prevent patients from serious negative consequences for health issues like aspiration or pneumonia or malnutrition, as well as negative impact on their quality of life, it's really important to try to diagnose and maintain care and like have it be on your radar for dysphagia, to be thinking about it. You may notice that you cough or choke on liquids. We do find that, especially if you're drinking through a straw, the straw moves the liquid really fast and at high volumes to the back of your throat. So it's more difficult for your body to grab onto, to understand the timing, and it may slip by before you trigger the swallow. So that's when some aspiration or penetration, when the liquid goes in and then it gets coughed out, can happen. It may feel like certain foods are really sticky in your throat. Now that could be especially drier foods or chunks of foods like meat. It may be particulate foods or foods that break into a bunch of different pieces like rice or potato chips, or like, for example, you're eating some peanuts and you notice the skins at the very, very bottom of the can seem to kind of get stuck or make you cough or irritate. So that could be happening as well. You may also have difficulty with pills. And they make pills in a variety of different ways. Some are nice and smooth capsules, some are small, some are horse pills that you can't even cut. So there are things that we can also do that are little modifications to that, that may be able to help as well. While we're on this slide, I'll just give you a couple of those. I can also send a handout with some common swallowing strategies, not to be used in lieu of an assessment, but just that can help at meal times. So some of the things that we recommend is that you don't eat distracted. And we live in a very distracting world. And I love like a pizza and movie night as much as the next person, but it's better and safer to eat with focused attention just on eating. It's also really helpful to take small bites and small sips, and to also make sure that you're chewing your food very thoroughly before you swallow. If you have trouble with liquids, I would recommend avoiding straws because they can make that issue worse. Another thing that can really help as well is if you're eating drier foods, moisten them. So if you're eating like a piece of toast, put some jam on it, unless you're diabetic. If you're eating something that's drier, have a sauce on it, or something particulate like rice. Rice and sauce is delicious. Okay, so sauces help, condiments help, something to moisten. You could also alternate solids and liquids. So if you eat something a little bit drier, chase it with a little bit of liquid, kind of go back and forth. That can be really helpful as well. When you are, and also avoid movement. This kind of also goes with eat with and drink with focused attention, but I would avoid walking and drinking at the same time. I'm bad at that. I think many of us are, but we don't want to admit it, especially if we're exercising. It's worth it to just pause, take a sip, and then return to your activity. If you're having difficulty with pills, you can always cut them unless they're a capsule, and then I don't recommend it. You can crush them, but what you run into is that it may really impact the flavor. I remember eating some mint chocolate chip ice cream that had like antibiotics sprinkled all over it as a child. And I had to eat that whole bowl of ice cream, and I've never hated ice cream except for that once. So if you're going to crush it, be careful what you're mixing it with. I would also recommend that if you have a tablet or a capsule that's not adequately coated, that is too big to swallow, or is that a little problematic, you feel like it gets stuck, you can actually coat it in a little bit of olive oil. So just take a tiny bit, coat it up, and immediately swallow it with water. And sometimes that little slippery bit from the olive oil is enough to help. You can also encase the medication in puree. So that means taking it with a bite of Greek yogurt or some applesauce or some pudding. That sounds even better. You can also speak with your doctor and your pharmacist about trying to find a liquid form or a smaller capsule. Sometimes the generics versus the name brands produce it differently, and one may be easier. And it's absolutely worth it, right? You want to do whatever makes your life easier that gets you your meds in the least interruptive way. All right. So hopefully this is not too ewy of a picture, but you see your vocal folds again. One of the ways that we assess for swallowing impairments is doing a FEES. You might notice in speech language pathology, you've already been exposed to this. We have a lot of acronyms, and those acronyms are a mouthful. Flexible endoscopic evaluation of swallowing. There's a reason we call it a FEES. Basically, this is where a speech language pathologist will stick a scope that is as about as thin as a piece of spaghetti in your nose while you eat and drink. So this is a way to watch you eat and drink through a full meal. So this is not going to be from here down, because it's really only capturing at the level of your vocal folds. Does any material go where it's not supposed to? Does it go into your airway? So what you can see here is that we've had this patient eat some pudding that has been that dyed with some food coloring. So the green is the food coloring, okay? So you can see that in the first picture, the green is entering where it needs to go. Now it's supposed to be diverted around the vocal folds, and then the esophagus, the sphincter will open and it will get pulled in. Now we can see that in some of these, it's kind of hanging out where it's not supposed to. So this gives us a lot of information about where the breakdowns are happening. And that can help inform swallowing therapy. Because if we know exactly what the locus is, what is the problem here, what do we need to improve strength or improve timing about, it can give us a lot of information. My colleague at Banner ENT, Kathleen Pizzato, is a board certified swallowing specialist, and she does these FEES there. So that's a resource for you if you ever need it. She's also at the university. The other kind of thing that we do, and many you may have had this before, this is really what is considered to be the gold standard for Parkinson's patients, is a video fluoroscopic swallow study, or a VFSS. I really call them an MBSS, the modified barium swallow study. So that's when we take you into an X-ray suite at the hospital, and we have you drink different consistencies of food and liquid that contains barium, which is radiopaque, meaning that we're going to see it travel down that X-ray to know exactly where it goes. So we'll know if it goes into your airway, if it hangs out around your airway, if anything gets stuck. And this is done with a radiologist who's also monitoring and doing little flashes of the X-ray to make sure that you don't have long exposure. So this is really helpful, especially for Parkinson's patients, because we want to see the whole picture, not just the level of vocal folds. We want to make sure that nothing's happening after it goes down into the esophagus too. So we recommend that patients with Parkinson's receive one of these pretty quickly after they're diagnosed, and that they have routine swallow studies every couple of years just to make sure that everything's okay. So here you can actually see, I mean, not only can you see this lady's earrings on the right, but you can see some of the barium as it's going down. So if you look at the second photo towards the edge of her neck here, you'll see this tiny little wormy actually see material from the airway and into the lungs. So that's what we hope we don't see, but this is part of why we do this. We want to make sure that there's a safe swallow. And if there isn't, that we can combat it. So in swallowing therapy, we do exercises to maintain the movement and strength of the muscles. We'll also teach you compensatory strategies. There might be different postures or different maneuvers. The last solution is changes in diet, but we don't want to do that if we can avoid it, because nutrition is so important. Food is related to quality of life. I love to cook and love to eat. I'm sure many of you do too, or just one or the other. Typically love to eat. So we want to make sure that there's no nutritional deficiencies, that no one is losing weight. So that is a very, very, very last resort. This isn't a scenario like, oh, I'll put off a swallow study because I don't want the SLP to take things away from me. I get it. But that is very unlikely to happen. Most likely everything will be okay. Or if it isn't, we'll continue to monitor it and we'll give you things that you can do in the meantime to strengthen your system. And this is what an SLP evaluation typically looks like. We'll collect a lot of information. We're nosy. We want to know all about your voice and speech, your vocal folds. We'll do a clinical swallowing assessment, just having you eat a couple different consistencies of food and liquid just to see if we notice or palpate any problems. Ideally, we'd order a swallow study so we can really see what's going on and do a cognitive or language evaluation if that's necessary. Then the most important part is trial therapy, trying some of our techniques and seeing what works. So when do you need us? When you notice a change that is worrisome or is interfering with your life. Different levels and types of services are often needed at different points in time. Our job, ideally, is to give you all of the tools and techniques and strategies that you need to make improvements to your voice and speech and swallowing, and then send you off to do that and check in and have maintaining appointments over time. Or perhaps you go through individual voice and speech therapy, and then you'll join a therapy group where you can socialize with other people and receive therapy strategies and have therapy in a group setting, which works remarkably well. I have a couple of questionnaires. I'm going to have you only do the CPIB if you have the tools to do so. So if you have a pen and pencil, I'd encourage you to take them out. If you don't, just think about this. I will email it to you later. And this is just checking in. You don't need to share your scores with anybody. This is just some food for thought. So this is called the Communication Participation Bank 10. So basically, these are statements that asks if your condition interferes with participating in these activities. All a little, quite a bit, or very much. Again, feel free to write them down if you like to. If not, just think about them. One of the reasons that we talk about these things and use this tool, besides that it has really good validation, is that sometimes there may be things that you hadn't really thought of yet that comes up in this, that is meaningful. So the first question is, does your statement or does your condition interfere with talking to people you know? So people who know your speech and your voice. The second is, does your condition interfere with communicating when you need to say something quickly? Like you need to relay a good amount of information and it has to be fast. This is also something that you could do with the people around you who are closest to you, or they could fill it out for you and you could compare notes. Again, not that we're looking for problems, but we just want to start conversations. Does your condition interfere with talking to people you do not know? So unfamiliar people, maybe over the phone or in person. Does that interfere? You might also reflect, like, does that change my level of confidence that I'm going to be heard or understood? Does your condition interfere with communicating when you are out in your community? I know this is also impacted by the pandemic, so you could answer for, the times when you have been out or when you are out. Does your condition interfere with asking questions in a conversation? Does your condition interfere with communicating in a small group of people? Does your condition interfere with having a long conversation with someone you know about a book, a movie, a TV show, or a sporting event? Or does it interfere with giving someone detailed information? Maybe someone asks you for directions. You shouldn't ask me, I'll tell you that much. This is one that my patients report a lot. Does your condition interfere with getting your turn in a fast-moving conversation? That can really impact whether or not you jump in and you participate, which is significant. We don't want you retreating. Does your condition interfere with trying to persuade a friend or family member to see a different point of view? Because we use our word choices, our speech, and our voice to be commanding, to be convincing, to say what we want to say. So again, I'm happy to send you a copy of this form, or I can send you a copy of my slides if you like. So you can access this at a later time if you'd like to too. And again, feel free to discuss your results with whomever you feel comfortable doing so. All right, let's skip that. Just so you know, and if you are scoring at home, higher scores are better. It means that there's less interference in your participation. I wanted to talk briefly about some resources in Tucson. We do offer comprehensive speech language pathology evaluation of speech, voice, swallowing, both in person and telemedicine at the UA Speech and Hearing Clinic. We actually will be starting or restarting our Parkinson'S therapy group, which meets weekly via telemedicine this spring, which I'm really excited about. We've had a couple of really fun semesters. And then we consistently see patients for evaluation and treatment at Banner and UA. And if you want other resources or recommendations for therapists in the area, or if you're in a different part of this study, I have a network and I'm happy to give you all the information that I have. We already talked about that. So let's try a couple of exercises that give you a little bit of an idea of the flavor of what we do. So I'm going to go through a couple of exercises with you. One where we'll talk about breath, one for optimizing vocal fold closure, and one for focusing on articulation. So this is kind of some of the basics of therapy, but a lot of other things happen in therapy. And again, it's personalized. Therapy should be tailored to your needs and what's working for you. And also your goals, right? That's important, especially with such high achieving and active adults. And then we will go into Q&A, unless you have other recommendations. All right, so I'm going to ask you to get involved at this time. For those of you who are in person and together, this will be more fun because you'll be able to hear other people. But wherever you are, I would like you to count until you run out of air. Start at 100, then take a breath and keep on going. That's after you feel like you're running out of air. I would like you to notice how it sounds and feels when you have too much or too little air. And feel free to contribute your perceptions. I expect to hear some counting or a jumble of counting people. So we're feeling how it feels when we start and we have lots and lots of air. And then we're kind of pushing past that point where we don't have very much air. Would anyone like to contribute their perceptions? I heard something, but I didn't quite catch it. Oh, I've got a chat. That's very helpful. Thank you. When running out of air, I start to whisper. Yeah, you might notice that your volume just totally decreases. Did anyone notice that there's a little bit of tension in the throat? Or did anyone notice that their voice quality deteriorated? I'll give you an example of mine. And instead of counting, I'll just say, I'm talking, because I generate really exciting content. All right, so I'm going to try. I'm going to take a big breath and I'm going to go. Notice, oh, yes, tension. Thank you, Diana. That's really helpful. It's good to hear your perceptions. So take a big breath and I'm talking. Number one, not comfortable. Number two, just like Diana said, yeah, there's some tension or some pain and tightness in the back of my throat. I totally agree. You might have also noticed that as I started to become more air starved, my voice quality deteriorated. You can notice it got kind of rough sounding. Yeah, it started sounding kind of hoarse and kind of like this versus my normal voice doesn't really sound like that. So a lot of this is about like the benefit of air. We kind of call attention to these exercises with several different things. The first being, how does talking sound and feel? The second, how does having the right amount of air change that? And how can we integrate that into our speech? That can be tricky because sometimes we don't get an adequate breath. Sometimes we don't want to surrender our turn talking. We want to be able to compete, so we keep talking. Or if you're like me and you're talking about a subject that you're passionate about, you tend to increase your rate of speech and it tends to go faster and you tend to take fewer breaths. Guilty, right? We all have patterns. We all have things that help us and things that may not be quite as efficient. So essentially, a lot of these exercises call attention to our airflow. We need enough airflow to make our vocal folds vibrate without using a lot of muscular effort. Like Diana was saying, she felt like there was some pressure or tension at the back of the throat. I can actually still feel that from when I was talking. All right, let's try another. All right, so for this one, I would like you to notice vibration in your lips, nose, and mouth when you do this. So I'm going to have you make a long B sound. So that B kind of turned into a V. Go ahead and try that. I'm giving you all sorts of sound effects to delight your spouses or friends or grandchildren. Children. Somewhere between a B and a V. You can also start slow and then get faster. Or you could make a V sound, as in Victor. That gives you a buzzy sensation too. I've got a new chat. I'm just going to look this. My dog is enjoying this. Fabulous. I have my little 8-pound poodle mix behind me, Pippa, and she just gives me that look like, what are you doing? But she's used to it. Good. Try it again. Whether it's a Z or whether it's a B sound. Notice that vibration in your lips, nose, or your mouth. And then take your finger. We're going to make it feel like so buzzy that it's almost itchy. Do you feel that against your finger? That's pretty cool. So what we're paying attention to is the feedback that we get from our body when we make certain kinds of sounds. And yes, I realize that as an SLP, I'm obsessed with sounds, but this is pretty fun. You can also do this with M, like a hum sound. Or mm-hmm. Everybody try that. See if you can get the same buzzy, hummy sound. Mm-hmm. Or one of my favorites, since I love to cook and eat, yum. Yeah. What do you notice? How does that feel? Feel free to chat or share or speak up. So one of the reasons we do this is because the voice can get hoarse, like it was when I was talking. One of the ways that we can get a boost, an acoustic boost, a natural amplifier, is to try to send the air towards our lips. You notice that suddenly I was carrying my voice pretty well, and I didn't push with it, versus if I'm talking, I'm pushing really, really hard. So it makes it easier and it makes the voice more efficient. So that's one of the things that we play with in therapy. You get to make all of the sounds, all sorts of crazy sounds. All right, now I've got a crazy sentence for you. Crazy compound sentence. All right, we're going to talk a little bit about speech precision, right? So I mentioned that with Parkinson's disease, dysarthria is often present. And dysarthria is that imprecise or unclear or mumbled or slurred speech. So we're going to play with one cue. I want you to think clear, crisp consonants. And I'm actually going to put that into the chat so that you can see it as a reminder. Oop, I am echoing. Give me 1 second. I think, John, if I mute you, you will be all set. Oh, we're good.
I already got it, Dorie.
Thanks so much. You are on it. I'm just writing clear, crisp consonants. That is what we're focused on. So I would like you to play with this phrase. It's going to sound something kind of like a big black bug bit a big black bear, made a big black bear bleed. Yes, I'm recruiting you all for the theater. So think of those clear, crisp consonants, take it at whatever pace you like. And then I'd like to hear what you thought of your voice and your speech. A big black bug.
Big black bear, big black bear,
This is fun to hear. All right, are we having fun? What, anyone want to share their perceptions? How did that feel, or how did it sound to you? What you might have noticed is that extra attention to thinking about articulatory effort, using your teeth and your tongue and your lips. A big black bug bit a big black bear, made a big black bear bleed. Ooh, that could have gone so poorly. It makes it clearer, a lot clearer. You might have also noticed that even though I was focusing on clear, crisp consonants, my voice sounded more engaged. I had more musicality, I had more pitch variation to my voice as that was happening. After saying it 5 times, my lips got tired. I believe it. Mine are tired too. But I will say it is better to have your lips tired than your throat tired. But especially those bilabials, those b, 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 b. Yeah, makes them a little bit itchy and a little bit tired. You don't need to use this as a repetitive training exercise, I promise. This was a little bit of fun and to prove a point. All right. If any of you are fans of singing in the rain, I've got a phrase for you. Diana said, I still felt tension in my throat, but not as much. Excellent. So one of the things that we actively work on is trying to identify when there is tension and when there isn't, and what kinds of sounds are associated with that. So my advice, Diana, would be to try to see if you can back off the effort even more. So maybe strike a balance between keeping it easy in the throat and also crisp. So instead of a big black bug bit a big bit, like I'm working a little hard. A big black bug bit a big black bear, made a big black bear bleed. I'm also focusing on my air. Oh, everyone seems frozen. Can you guys hear me and see me?
Yes.
Okay, oh, thank goodness. Thank goodness. Okay, so this phrase is from one of my all-time favorite movies and musicals, Singing in the Rain. Singing in the rain. All right, so Moses supposes his toes are roses, but Moses supposes erroneously. So what I would like you to do with this phrase is I would like you to pay attention to one thing, how the sounds feel in your mouth. You're just noticing the feedback that you're getting from your body. So I would like you to stretch these sounds. Moses supposes his toes are roses. Breathe. But Moses supposes erroneously. If you want to be super dramatic, you can erroneously. Oh, this is great to hear. Yeah, stretch those sounds and pay attention to how they feel in your mouth. It's going to bring out different dimensions of your voice and speech. Yeah, go ahead and try it again. It's fun. Excellent. Yes. Any takers to share? I can't seem to see the chat any longer, but feel free to speak up. You may have noticed that your voice was more musical. You may have noticed that you had more air. You may have noticed like, oh, wow, some of these sounds give me a little bit of feedback or vibration. Moses supposes, right? Some of these sounds give us feedback that tell us we're on the right path. So I challenge you to think about that next time you're having a conversation with someone, or if you're reading this phrase, just because. Think about how these sounds feel in your mouth. See if you can have fun really trying to bring the text alive. All right. I've got another one for you to feel those sounds in your mouth. Round and round the rugged rocks. If you want to make it extra special, go ahead and flip your R's. Round and round the rugged rocks. If we all want to be Sean Connery for a hot second. Or just stretch it and feel the sounds in your mouth. So you may notice that a lot of what these samples of voice therapy are doing is drawing your attention to things, right? To giving you cues that bring out different characteristics of your voice and can help you be more aware and help you troubleshoot. All right. Lastly, I've got a couple, actually not lastly, I've got a couple more, but then we'll go into questions. I want to leave a solid 10 minutes for questions at least. I'm going to give you a couple of statements and we're going to do them all several times. So my first sentence, I would like you to speak with intention for the meaning of the phrase, intention to communicate, with some energy behind it. And luckily your phrase is happy birthday.
Happy birthday.
Good. Now say it totally deadpan. Happy birthday.
Happy birthday.
Yeah, that was no fun. put intention behind it. Happy birthday! Well, thank you so much. No, my birthday's in August. That was great. There was so much energy there. There was energy. There was big contours and pitch. It was beautiful. Good. All right. Now let's try that deliberately for pitch. Happy birthday.
Happy birthday.
Nice. So we're changing the pitch. Let's change the word stretch. Happy birthday.
Happy birthday.
Good. And as if we were not exaggerated enough, I want you to exaggerate that intonation. Happy birthday.
Happy birthday.
I love it. I can hear you, John. Fabulous. Excellent. Let's try a couple more. How about let's go out tonight? First, say it with intention. Whatever that intention is, put it behind there.
Let's go out tonight.
All right. Now let's change your pitch. Let's go out tonight. Let's go out.
Go out tonight. Let's go out tonight.
Open your faces. Now, shards, right? Oh, that's what we've lost.
I think we've lost her.
Yeah, we did.
Yeah. We're kind of running out of time anyway. We are recording this. It will be put on our YouTube or on our website. So if you had trouble reading the screen or it was moving too fast, feel free to look at the recording on our website. I'm not sure how soon it'll be put up, but as soon as we can. Looks like
Fun exercises, Sharon.
It's really a good program.
Hi, Cindy.
Cindy, can you hear me?
Yes, I can.
Okay, our time is running out.
And I don't have it, there's no, there are no questions in the chat box. So, and Dorie is kind of a blank screen. So I think we are done.
I think so. If Dorie comes back on, tell her thank you. It was very interesting.
What? Do we have a phone number for the doctor? Contact?
I probably do on my computer at home. I'll
Okay.
check that out. I just want to mention that we do have a speech pathologist in Green Valley at La Posada.
Oh, really?
So if you're interested in taking speech therapy, you can get a referral from your doctor and you'll probably end up going there because that's the only one I can think of that we have. Anything else, John?
Well, I do have contact information. If you do want to get in touch with Dorie at the university, I've got a couple of numbers here. Her administrative assistant, which is probably the best person to contact, is the area code is 520. It's 621-1826. And she's
Hi, y'all.
located. Oh, we're back. Everybody
So
get-
sorry I lost you. I'm back.
Oh.
I'm sure you were probably in mid-sentence of let's go out tonight, and I disappeared. Let's go out tonight, and I made a quick exit. Sorry.
Dr. Dorie, this is Charlene.
Hi,
Um,
Charlene.
Those of us here at Las Campanas need to leave because we have the room only to 2:30.
Oh, I'm
but
so
I
sorry.
I wanted to tell you that we found it very interesting. And so we'll be putting your recording on our website and so that If you want, people who weren't here will be able to watch it.
That would be great. I'd also be happy to be a resource. If any of you have questions, feel free to drop me an email. You can also give me a call. I'd be delighted to speak with you and help with whatever I can, or just chat or answer questions about something. Charlene, if it's of interest, I'd be happy to send you some handouts that you can also post if you'd like.
That'd be great. Thank you very much.
Thank you. This was a pleasure, and I'm always happy to return if you need me.
I've put the phone number in the chat box. If you look in your chat, I've put her contact number in the chat.
Where's the chat box? And I'll also include my email. The good thing is it's easy to remember. It's dorie@arizona.edu. And it doesn't matter if you contact me a week from now or a year from now. Just remind me that I met you here, and I'm happy to answer whatever, help whoever way I can.
1826, that's her administrative assistant.
Okay, thank you very much, Dorie. I'm going
Thanks, Cindy.
Yep, end this meeting. I think everyone has really found it informative, and we appreciate you giving your presentation. So,
It's been my pleasure. Thank you all.
great.
Thank you.
Bye.
Bye.